Our first line of business is we have Dr. Rick Barr. Is he on the? Is he on?
He
Yes,
is
I'm here.
Ms. Hatter.
Oh, there
If
you
I
are.
could,
Oh,
if,
Yeah.
if I could introduce him just for a second, please,
sure.
and then we'll turn it over. We actually have, as shared by Ms. Noland, and I want to also welcome our public tonight that are watching, whether it's on Facebook Live or on LRSD TV. Reminder that this all gets replayed over and over and is accessible. So if you found this interesting, please do share it with other community members, because I think it will be a very informative couple of hours that we get to spend. Um, as I reached out to both of these gentlemen who are really, people that are right there in the mix of a lot of different things within our community and specifically within their organizations, they were really automatic yeses and said that they would jump in to support and help. And I'll say something about each organization so that I don't have to do it for both. But with I'll start with the Department of Health and Joel Tumlison. If you pay attention to the newspaper, in fact, today he was the one that was quoted. He's kind of a person that's right there with Dr. Romero and Dr. Delahaye, and then there's Dr. Tumlison, who is helping the Department of Health guide through the different things, and that's interactions with the school district, with the communities, with the hospitals. And in particular, Dr. Tumlison has a specific charge to support the youth of this state in terms of this pandemic. And so we really couldn't have found a better person to help. He has been readily accessible to us at LRSD when we called and asked for support. Dr. Rick Barr is really the right hand to Marcy Doderer. And I do want to thank Marcy Doderer from Children's Hospital, who is just time after time always finds ways to support our district, whether it's in providing apprenticeship programs for career tech students, to being a part of our leadership academy, to supporting us on an evening like tonight. Dr. Barr is, right in the mix of, what the impact of this pandemic has within our community, as well as within our kids in the community. And it's important to understand with both of these gentlemen from a medical side that, if we, and I've said this clear back from when the pandemic began in March of 2020, that if we have to really understand what's going on in the hospitals to understand what we as a school district may have to think about and do, because the hospitals are critical. If we don't do the right things to support them and be there for them, we're going to end up causing a bigger problem in our overall society. So hospitals are critical, and we've got two great gentlemen to speak to us. So, these guys got parameters of saying we need you to deliver about a 10-minute speech, and then we wanted, or a presentation, then we wanted to open it up to all of you to be able to ask some questions. We'll start with Dr. Rick Barr, and Dr. Barr, we'll turn it over to you, and I know Jeremy is ready to help you with your PowerPoint.
Great, thank you. I do have a few slides prepared, but let me just open up by saying I deeply appreciate the work that you all do as a school board and highly respect the education system. I've always said that, if I could pick one health intervention that would make the most difference for the health of kids, it's actually education. That improves health outcomes across the board. Joel Tumlison and I have already done a lot of collaboration. We worked together on a task force back in the fall, developing the Ready for Learning Back to School Guide. That it was a collaboration between UAMS and Arkansas Children's and the Department of Health and Department of Education. Hopefully that guide was useful as you all prepared for kids going back to in-person learning. So I just have a few quick slides, and then I'll be happy to answer any questions. Again, I'm a pediatrician, and specifically a pediatric critical care physician is my specialty, but I do a lot of general pediatrics as well. Next slide, Jeremy. So what is the experience at Arkansas Children's with children infected by COVID-19? So during the pandemic, since March, we've had 182 children who have been admitted to Arkansas Children's here in Little Rock. And then additionally, another 52 children admitted to Arkansas Children's Northwest who had COVID-19. And that may seem like a fairly high number, but that's only about 2% of our total hospital admissions. So we you know, admit over 10,000 kids a year to both hospitals, and not all of these kids really had symptoms. Many of them were incidentally positive. We test everyone that's coming into the hospital. Many of them are incidentally positive, and were coming into the hospital for some totally unrelated reason to COVID-19. And that I just make that point to demonstrate that children really don't get acutely ill with COVID-19 respiratory symptoms. We still don't understand exactly why that is, at least enough to require hospitalization. They have very, very mild symptoms from COVID-19 as opposed to adults. Now, we know kids are about 15% of our positive tests are kids. They just don't get severe respiratory symptoms. They can develop a post-infection multi-system inflammatory syndrome, which we call COVID-19 MISC, and that can occur a month or two after a COVID infection. Next slide, Jeremy. So what is the COVID-19 MSCI? It's a post-infection multi-system inflammatory system that can affect the heart, kidneys, joints, skin, etc., and can make kids really sick. This is where you've been hearing maybe that somebody that playing sports after a COVID-19 infection was discovered to have heart problems and have myocarditis or inflammation of the heart. This is what you're hearing about in the press in terms of a inflammatory syndrome. We've seen 18 children over the past 9 months or so that since the start of the pandemic that have had MSCI, some of which have been fairly sick. So thankfully it is rare, but kids can get sick from this component of a COVID infection. Next slide. We don't have really good data on can kids transmit the infection, mainly because many children have absolutely no symptoms at all. In settings where good contact tracing has been done, children are probably infected by adults in their household, not the reverse. So although we know children can transmit the virus to others, they probably do so much less than adults. We don't have any data on children and the new British or South African strains that we know are rapidly spreading, and we presume are here in Arkansas. We presume that they're fairly widespread, but hopefully we'll have more data on that soon. I do want to touch on some of the non-health implications. These are health related of the pandemic on children. We know social isolation, mental health issues are really exacerbated by any stress, and we know that those have increased during the pandemic. We're seeing more episodes of child maltreatment and child abuse presenting to the children's hospital, so we know that has gone up during the pandemic. Food insecurity is clear, and I'm thankful that our school system is one of the responses to food insecurity and being able to deliver meals to kids. We know that remote learning challenges exist, and remote learning is not equal across all environments. So that I know that's something that you all struggle with. And access to other services such as school nurses or other services provided at school are a challenge during remote learning. All these are exacerbated by poverty. We know that kids in poverty, you just multiply the issues listed above. Next slide. And finally, I want to make short comments about the COVID-19 vaccine. It is very effective. Every vaccine that's been approved has been shown to be 95% effective or greater. We know there's a slow rollout, and we would like to see as much as anyone that we get more vaccine out to those people that need it. I would note that the vaccines are not approved. They were not tested in children less than 16. So The vaccine trials in children are just starting. It'll be a while before we have a vaccine that's approved for use in children. And if you want some great information about the vaccine, I included the link to a YouTube video prepared by Dr. Jessica Snowden, who's our lead of pediatric infectious disease here and an expert on COVID. And she's has a great, it's an 8-minute video. It's well worth your time to watch about the COVID vaccine that answers a lot of questions. That's my short slide presentation. I'd be happy to, when Mike says it's appropriate, to answer any questions you all have, but I really appreciate the opportunity to come and chat with you all.
Ms. Hatter, if it would be okay with you, it might be good just to have Dr. Tumlison follow right behind and share his comments, and then the questions could be kind of shared between them, if that's okay?
Sure, that's fine. That was my line of thinking too. That's how I thought it would go.
Okay.
Thank you.
Dr. Tumlison, we'll turn it to you.
Hello, everyone. Good evening. I'm Joel Tumlison. Can y'all hear me okay with this mask on? Okay, good. I am a family physician by training. And when Dr. Barr said that I have a special role with children in this pandemic, one of my jobs here at the Department of Health is as the medical director for child and adolescent health. The other part of the health department I work in is in outbreak response. So most of it has been outbreak response since the pandemic started. However, the areas that I'm involved in specifically with the Department of Health's response in this pandemic are specifically with schools, also with childcare, working with DHS, and I'm involved in sports, mainly in those sports that have to do with schools and children. So that is some of my overview of my role here right now. I just want to give you a little background about what were we thinking about when we started planning for schools going back into classes after the summer. In trying to think about what we needed to do to help schools respond, Dr. Barr already mentioned the work that was done as a collaboration with UAMS and Children's Hospital and other people in the community and the Department of Health and Department of Education to put out guidance, but specifically in trying to get ready for how schools would respond to individual cases. What would they do when they had cases? Because it was going to happen. There were going to be exposures at schools, and how would they be able to handle it? In working with AD, we decided to try and set up what is basically kind of an early warning system. We knew that schools, if the students who were positive just went through the normal process of getting contacted by a nurse from the Department of Health or one of our vendors, finding out bit by bit their contacts, then that information going to the contact tracer, and then that contact tracer calling one little by little to those contacts. We knew that those children, especially if they're young children, they probably are not going to remember who they're around at school. They're not going to know who they're sitting with, who they had close contact with. So trying to set up a system in which the school could, one, help provide that information, but two, also know what they needed to do and respond early instead of being behind the curve and late. And that's really what it's turned out to be. Now, this system is dependent on a lot of hard work from school districts. And I've been impressed with how school districts, including Little Rock School District, have adjusted and have points of contact. A lot of it is centered around points of contact. That's the person for each district. Some districts that are big, like Little Rock, have multiple points of contact to communicate with the Department of Health. We have a hotline room set up with staff from ADH and ADE that help answer those calls and take those reports in. Now we've got a web-based reporting system that the points of contact from school districts report cases that they find out about to us through that. Because we realized, the first person to find out about a positive test is not the Department of Health. It's hopefully the patient themselves. And then pretty shortly thereafter, the parents of that case, if it's a child, or the case themselves, if they're a school employee, are going to call the school and let them know. So the school knows before anybody else does and they needed to know what they needed to do. So that is why we set up kind of that early warning system with the hotline to try and be able to give early advice, intervene early to prevent further exposure and further transmission. So that is kind of the system that we set up. By now, lots of the schools know most of what to do, and they call us mostly with kind of strange cases, outliers, things that aren't typical. But what have we learned from some of those interactions with school districts on the system, the points of contact, and as Dr. Poore mentioned, consults that we do when a school district as a whole has a question about, okay, we're seeing this, we've got this many cases or this many people in quarantine, what should we do? We kind of have a consult like this, and we compare numbers and compare notes, and then talk about advice we can give the school district on what plans they have, if those plans that they already thought of were good and they should go forward, or if they need to tweak them, or some other ideas we might have that they hadn't thought of. I think that's gone well. I hope that has been helpful for districts. Things I've noticed is that schools are working very hard and very diligently in this process. We know that it's a very heavy lift. This is something that school districts didn't have to consider almost at all in years before. And suddenly, so much of the school year is revolving around how they've adjusted to COVID, much less having POCs that are basically dedicating their full time to tracking COVID in schools and how it's going. So schools are working very hard and doing a very good job. One thing we've noticed is lots of the times when a school or a district has to transition from normal on-site instruction to some other change, whether that's virtual or part virtual, maybe it's a class, maybe it's a school. A lot of time that decision has not been due to large scale spread in the school. It's often due to staff availability. Superintendents and principals saying, I just don't have enough teachers right now, between a few being out as positive cases, others that got quarantined from exposure to family members, or maybe a coworker being out due to quarantine, and they just can't fill it in a way that allows them to effectively teach on site. And that has led to a large number of the shifts or the transitions to other virtual learning, et cetera. And I would say one other thing we've seen is that most of the cases in schools don't contract it at school. Most of the cases in schools contract it elsewhere, most notably from their family, which makes sense, but also other community activities or things they're doing outside of school. Where we have seen spread in schools is most often when there is spread in school, it's in a sports team, because it's hard to play basketball. It's hard to play some of these sports without tolerating close contact. You wouldn't be playing them. It wouldn't be any form of a normal sport. And that is there have been rare occasions where we've seen in classroom spread from one person at start, and then we get 3, maybe 4 or more spread in the classroom. But generally, I mean, that's been a handful of cases around the state. And what we've usually seen is if there is a spread in a classroom setting, that it's maybe from one person to one other person, or maybe 2. It's not extensive classroom spread. And that's because schools have taken so many measures, multiple measures at the same time, like masking, like spreading the seats out as far as they can, like changing classroom schedules, changing transition schedules, changing the way they do lunch, the way you do pickup of children, busing, all those things, that hard work they've done based on those suggestions, like in that document Dr. Barr mentioned, are having a good effect on keeping the number of cases of spread in the classroom down. Mr. Owo, Dr. Owo, do we have, can we share screen? Actually, I see it right here. I want to show you a graph, if I can, and show you this. This graph compares cases of COVID in the Little Rock School District here on the top with all public schools, K through 12, here on the bottom. Are y'all able to see that? Okay, so it basically, this gives you, the bottom is the date of illness onset. So when the person got sick, in the case, don't compare numbers to numbers. Obviously, you're one district and this is the whole state. But this is called an epidemiological curve. What I think is interesting is notice here in the state as a whole, we're kind of rocking along. Cases are going kind of slowly trending up along here. And then right here, we see a jump. What was that jump? That jump was Halloween. That occurred right after Halloween. And in a lot of schools in the state, they saw a significant increase in cases right after Halloween. And you see it jumped up there, and then it kind of started to trend down before jumping up again after Thanksgiving. And then it's kind of been high since then. In the Little Rock School District, it's trended up a little bit, a little down, but notice there's no huge jump after Halloween. So Mr. Poor and staff, I don't know if y'all just did amazing communication to families, or the families in the Little Rock School District were just better about not letting kids have crazy Halloween parties or what, but you didn't see the same curve. But you can see that since then, along with community rates, we're seeing increased trend up, just like the rest of the state, just like you see here, but increased trend up since November, and then here after Thanksgiving, and then here through the new year. So I just wanted to show that to y'all, to show that kind of epidemiological curve. That curve that you're seeing with the Little Rock School District, with the exception of not showing this Halloween jump, that's very similar to the curve in the state as a whole, which is what we've mostly seen with cases in school districts. They tend to mirror the way cases are going in their community. And then the other thing I wanted to mention was vaccination plans. I saw Ms. Margot Bushmeyer was on there. The phase that we're in right now is phase 1A. As far as the school district is concerned, who's getting vaccinated in phase 1A? School nurses and school health staff. Those that are working, that are healthcare workers in the school district, are ones getting vaccinated. I know that I saw an email that had a lot of the plan that Ms. Bushmeyer and others in the Little Rock School District put together. And I really liked that plan. I thought it was really good, the way y'all coordinated it with the local pharmacy and got appointments set up for your workers to get vaccinated. Now, when will other Little Rock School District staff, and which ones, get vaccinated? So all school teachers and staff, not a distinction, basically anybody that's working on school campus in education are included in phase 1B. We're hoping to move to phase 1B by the start of February. Maybe a little sooner, but that's the date that we're looking at moving to. And so that is when we hope to start vaccinating the groups in phase B and phase 1B. And school staff is included in those frontline essential workers that are in phase 1B. And so that is coming soon. You know, vaccinating the all the members of the Little Rock School District staff and is going to be a challenge, simply because I believe Mr. Poor, I'm remembering this right, he told me there were 3,400 staff to be included in that. So that's not an insignificant number of people, but based on the plans that I saw Little Rock School District had made previously for the school nurses and health staff, I am sure that y'all are going to come up with also a good way to do that in conjunction with local pharmacies and those who are providers in phase 1B. So I think I've probably used up about 10 minutes. So I will stop now and give it back to you, Ms. Hatter, for questions.
Thank you for that presentation and that information. I will open up the floor for questions back from the other board directors. And sorry, I'm changing my view so I could see all of you guys. Okay. I thought I saw Director Woods unmuted. Director Woods, do you have something?
Well, I do have some questions. I wasn't trying to be eager beaver and go first or anything. Maybe I just accidentally left my thing unmuted. But I do have some questions. Dr. Tumlison, these may go for you just based on some of the things you just told us. Talking about LRSD specifically, are you familiar with LRSD's Ready for Learning plan, were you involved at all in helping to craft that, or have you reviewed it or reviewed it since it was implemented or anything like that?
I have not seen Little Rock School District specific one. I did work with Department of Education on kind of the framework of Ready for Learning, but that was more kind of the statewide kind of document and planning. And I don't know, Mr. Poor, if y'all kind of took that and then modified to make it specific for Little Rock School District.
Well, I'll go ahead, Mr. Poor.
Yeah, that is correct, and we did take our own approach, and then we worked with, we had to get the Ready for Learn plan adopted or received by the Department of Education, who approved it.
Dr. Tumlison, even though you weren't involved in the crafting of the Ready for Learning plan for LRSD specifically, have you worked with LRSD over the course of the fall semester when it came to making decisions about classrooms and grade levels and school shifting to all virtual?
Yes, we've had at least a couple of consults that I can recall, you know, formal ones kind of like this, as well as a number of other email communications, phone calls, just instead of the whole crew getting together, just a one-on-one call between a few people. And we've done that, and I think those calls went well. I have talked with Margot Bushmeyer a number of times about things that were going on that she was seeing, finding information from her or trying to help with some advice when able.
Okay. In working with LRSD, do you believe that LRSD is engaging in the best practices that it can engage in promoting student safety in our buildings? And so I'll leave you that open-ended question, but then I'll open it a little further for you. Is there any critical review of LRSD's practices or policies in your experience with LRSD that this new board should be aware of?
What I've seen of LRSD's practices and in the interactions we've had and looking at cases, I don't see anything egregious. A number of the things that I've seen look like very positive things that they put in place. And particularly I was impressed when there was you know, some sports team issues. There were cases. How many do we have? I liked the response and the cooperation that school health staff gave in working with us to try to set up testing. That went really well, I think. And that has, you know, that first time helped even future times that have gone on since then. So from what I've seen, I think the practice they've implemented have been good.
Okay. Have you been involved in the decision-making process to shift schools or districts to all virtual education in other parts of the state?
This is, 1 second, I'm gonna pause for a second. Director Woods, I'm definitely gonna have Dr. Tumlison answer that question. And then if you have further questions, we will come back to you. Okay. I see a couple have unmuted, but Dr. Tumlison, please, go, you have the floor.
Yeah, that Director Wood, is kind of the purpose of the consult, is when a school is wondering if they need to shift or they want to, they think they ought to. We have the consult with the different other ADH people that work with me, and ADE people get on the phone with the school district, you know, depending on who they want to be on the call, discuss the numbers, what's going on, what are you seeing, and what's the appropriate response. And so we talk about that with them. You know, often it is, this is, the school leader says, this is what we're seeing. You know, what are y'all seeing in your numbers? We compare notes, and then they say, this is what we were thinking of doing. Is that reasonable, or do you have other suggestions? And then we talk about it and make those decisions. So yes, we've been doing that kind of type of consult regularly.
Okay. Chairman Hatter, I do have a few more questions, but I'm obviously going to defer and let some other people have something to say now and scratch their curiosities. Thank you.
Appreciate it. Thank you, Director Wood. Director Nolan, I see you have unmuted.
Sure. And I may end up covering some of the same topics that Mr. Wood was also going to ask about. So one, and this may be for Dr. Barr, MISC, as I understand it, is something that we had not seen before COVID. Is that correct? Is this something new related specifically to COVID? And it's a kind of a two-part question, because my next question is, I have heard from friends who are medical doctors, who are also parents, who have expressed concern about there could be long-term effects that we just don't know yet, that some viruses do manifest with other issues down the road. And so I just wondered, is there research being done, or is there any way to know whether or not MISC is really the only risk that we're seeing to children, or if there are other things that we just may not be aware of yet?
Yeah, both are really great questions. Yeah, MISC, the constellation of inflammatory symptoms are somewhat unique to COVID, although it really patterns things we've seen before. There's another disease entity called Kawasaki's disease, and it's been around for a long time, and it's another inflammatory syndrome that we think follows different viral infections and has been described for 50 years. And when MISC popped up, we noticed this looks a lot like Kawasaki's disease. So yes and no, but with Kawasaki's, we don't see it affecting, we do see it affecting the heart, but not the kidneys and, some of the other organs. So MISC, we've certainly seen this with other viral infections. This seems to be more accentuated with COVID. To answer your second question, we don't know the long-term effects of infections on kids or adults. This is a novel coronavirus. Now, coronaviruses have been around for a while, and we've seen them in pandemics previously. SARS and MERS were both coronaviruses, and we know a lot about coronaviruses. In fact, that's probably why we were able to develop a vaccine so quickly, is we knew already a lot about coronaviruses. And we're just going to have to, it's hard to tell. We are going to continue to follow kids, particularly that have had MISC or COVID infections in general, for any long-term effects to see what's there. So we don't have a good answer to that question yet.
Okay, thank you. Well, that is an answer, because it is, a concern that I've heard, and it's something we're going to have to wait and see as time progresses. The other question I had, I think this is for Dr. Tumlison, you talked about consulting with districts to potentially switch to virtual learning. Is there a specific set of criteria that are used? And if so, what are those criteria? Or is it something that, a decision is made for each district, and it may not meet, a centralized set of criteria that is applicable across the state?
Yes, Ms. Nolan, it's more like the latter. There's not one specific trigger point. So what are the main thing we're looking for is, can we see signs of spread within the school? And if so, how big is it? Because that would obviously, drastically affect our decision. We need to get that extinguished if there is signs of spread in school. Like I said, that hasn't been that common. And by and large, when it's been in a situation like a sports team, et cetera, the schools have already done a good job of, getting those kids quarantined, recommending quarantine, getting them separated so that you don't get ongoing transmission in those. So one thing is there spread in the school that we can see? The other consideration taken into effect is, how is it affecting quarantine numbers? Are there enough people from however many cases there were that caused close contacts within the school such that then it's hard to continue educating, not because they're spread in school, but because maybe enough teachers are out or enough students are out of the classroom that it's just hard with half of them gone home, to continue the normal education. In those cases, we look and try to ask questions and find what practices might the school be able to improve on to limit the number of exposures. But generally speaking, when we start asking those questions, there aren't obvious glaring problems with the procedures the schools are using or not doing. Occasionally, there's one or two things that they could improve that we suggest they start doing and changing. And that's another thing I think I've seen from the schools is they've been good at identifying shortcomings and then changing so that didn't affect things in the future. Another consideration is the level of community spread, because that will affect, our recommendation depending on what is going on in the school. But we don't use the level of community spread alone as the only factor in deciding on recommending going virtual or coming back.
I was going to follow up with why not. The reason I'm asking that is there an indication that if you have widespread community spread in the community, that you won't also mirror that in the schools? Or is community spread a pretty good indication of where the schools are going?
Yes.
I hope I am clear with that.
As the graph, that I showed you the rise in cases in schools tends to mirror the rise in cases in the community, because we all live in families. We're out in the community. We're not at school all day long or night. And so that is bound to happen. But unless the other side of that is, are we, depending on the level of spread, do we want to make a statewide decision to just close schools like last spring, right? And that's not been desired by almost anyone as far as I can tell. Now, some schools, when they're seeing that level of community spread impacting their school in a way that makes it difficult to educate, then we take the combination of the community spread with what's going on in the school into account in considering, how to go virtual and for what period of time on that recommendation.
Okay. I'm going to be very quick. I'll be very quick. I have two more. We can skip and come back if we need to do that, but I can get through them pretty quickly if needed.
Okay,
the next one was also for Dr. Tumlison. And this is something that has been on my mind. I don't know if other school districts are doing it, and so I just wanted to get your thoughts on it. Are there any districts that are doing third-party audits of compliance practices for things like social distancing and mask wearing and things like that? Is that something that the state and the health department are doing, or is it something that, for example, a district could partner with, for the College of Public Health or something like that, if we wanted to make sure that we were implementing those recommendations as well as we possibly could?
Yeah, I don't really know the answer to that as far as third parties, outside of ADH and ADE. We have sometimes done that in conjunction with ADE, to assess what schools are doing and see if there's, any holes in what they're doing. But I don't know how to answer about third parties doing it. I've not heard of that, but I don't have any other information.
Okay, Director Nolan, I'm gonna pause right there, and I don't see anyone else that have unmuted. So I am going to go back to Director Wood for him to finish his last couple of questions.
I tell you what, Chairman Hatter, I really appreciate that, but I would defer back to Director Nolan just so she can kind of finish her thoughts and ask her question, then come back to me when she's done. I'm totally fine with that.
All right. Well, thank you, and I will be quick. The reason, just for full, disclosure and transparency, one of the reasons that the third-party audits came to mind is because I have been getting quite a few questions and comments about, well, the reported numbers are X, but I have concerns that they are higher. And so I just was wondering if there were any mechanisms in place to kind of verify or make sure that we were complying as well as possible and reporting as well as possible. So that was what that was about, and we can come back to that with Mr. Poor. The other thing I think I would be remiss if I didn't mention, and Dr. Barr, this may be a question for you. We're talking a lot, rightfully so, about the concerns for children because district and obviously we serve children, but we also are a very large employer and we have quite a few adults in the schools. I think has been missing quite a bit from the conversation about the COVID risks to children versus the risks of isolation. So social and emotional health and food insecurity and very, very real concerns like that. Is the emotional well-being of children when it comes to having a family member, a parent, a grandparent, or potentially a teacher who is critically ill, or potentially they lose a family member from COVID. Is that part of the equation when we're looking at children? Have we really looked very much at, I want to get into the actual risks to the adults and talk about that separately, but while we're still talking about the risks to children, we can't ignore the fact that having so many sick adults and having so many Arkansans die of COVID has got to be impacting children as well. And so is there some part of this that taking care of adults will help us also take care of children? I guess is what I'm trying to get at.
No, I think it's a great question. I don't think there's a good answer to that. I think every major decision like this has what I call a risk-benefit ratio, and that you've got to balance what there's a risk to there's a risk to social isolation, and poverty exacerbates that. There's a risk to being in school, and certainly to all the effects of possible transmission to adults that have comorbid conditions. It really comes down to weighing all those risks and trying to make what are the best decisions for the kids in that environment. And there are no easy answers. It is a really hard question. And yes, children emotionally have really struggled through this pandemic through multiple ways, with the stress on their families, with the stress on their learning environment. So it's just a tough environment right now. And until we get a large number of the population vaccinated and we can get control of the viral spread, it'll continue.
Hey, Dr. Barr, I just want to add to your question real quick, or your comment to the question is, you also shared an article with us that we will send to the board, but it's an article that deals with, I think, exactly what Director Nolan was bringing up. And you just want to give a quick commercial about that article, and then Dr. Owa will share that in the chat, and then we'll also send it out as an email and also put it on our website.
Yeah, it's I did a little bit of a literature review preparing for this meeting, and talked to our developmental pediatricians here at the Children's Hospital who are experts in child development, figure out what data was out there on the social and emotional and mental health risks to kids during the pandemic and with social isolation. So it's actually a pretty easy read. It's a 5 to 6 page article prepared by the McKinsey Consulting Group on what are the effects, those effects of kids in the pandemic. So yeah, we'll distribute that, and I would encourage you all to take a look at it. It's a fairly easy read.
Thank you very much. I have concerns about the actual health effects for adults, but I'm not sure that this is the correct time to dive into that. And it may be more specifically aimed at our administration and talking about how we can address those things. So I think those are all the questions I have at this time. Thank you very much.
And Director Nolan, then we would, depending on timing and placing, then we might be able to address that as well, because it does go along with the COVID conversation. I do not see anybody else that, well, Director Johnson, do you have something? I see you unmuted.
Yes, I do.
Mm-hmm.
This could be for Dr. Barr or Dr. Tumlison. We know definitely that we do not have a vaccine for 16 and under. Is that correct? We will not be vaccinating 16 and under. Is that correct?
The vaccine's presently not approved for 16 and under, so we won't be doing that now. We're testing kids right now, so hopefully in the future, I don't know when that will be, Dr. Tumlison may have a better idea. Yes, we will be vaccinating kids in the future when the FDA approves it for use in children.
Okay, so part two to that question is, should the district and the parents be concerned with bus drivers that have maxed out capacity on their buses? That could be 36 to 46 kids. So we know that there's no social distancing there. So should that be a concern? Is that something we should give some attention to? Either or.
Yeah, I'm going to let Dr. Tumlison answer that. And in terms of, I'm always concerned about social distancing. That we know that social distancing, wearing a mask, washing your hands, those are key to decreasing transmission of the virus.
So if a bus driver has capacity, we need to focus on that. Is that correct?
So let me just interrupt real quick before Dr. Tumlison answers.
Okay.
One of the things that we want to do is try to make sure we have factual information. So one of the things we can prepare for you in a report, if you'll give Mr. Bailey a little bit of time, a day or two, is to show average load on buses. That will help you on this. The second thing is that we also committed last week, to make sure that all of our contracted services employees will also get the vaccine. That would include the first student bus drivers. That will include the SSC custodial crew group. That will also include our will substitutes for teacher positions. They got a survey, I believe today, that lets them go through the same survey that the LRSD staff received. And we'll be talking more about that survey later today, but it's out there. So I just want you to know that we are being proactive in supporting those adults as well with virus protection. Dr. Tumlison?
Director Johnson, I'd say yes. Clearly, we want the students, everyone, to spread out, as much as they're able. So the things that have been recommended are, as much as you can, space out the seats. If there are siblings, seat them together because they're already exposed to each other, and as much separated from others as possible, to try and have assigned seating on the buses, because that helps later on. If there is someone that was positive on the bus, if they're in an assigned seat, you know who was closest to them and most at risk. And certainly wearing masks on bus is very important.
Thank you.
Okay, thank you for those questions. I just to wrap up, because we exceeded our 10 minutes of questions. However, I do have just a clarity question, and this is probably more so for Dr. Tumlison. This goes back to being able to switch to virtual learning, and I just want to make sure that I was clear in hearing you. And so there is not a metric or a rubric or a targeted evidence-based data you guys are looking at to determine whether a district is able to switch to going virtual. Did I understand that correctly?
Yes, ma'am, you did. There's not one number of, say, level of community spread that is meaning, oh, you're over this, we think you ought to shut down. Below that, you're completely fine. We have to take the other factors we talked about into account. Likewise, there's not a specific number, like, oh, well, if you've got 10 cases in students in your district, you need to shut down. Because 10 cases in one district might be, that's a lot, you need to shut down. But in the Little Rock School District, that would mean virtually hardly any cases. So have to take those data points in a comparison with the district, their enrollment, and in what the situation was. Because if you have, even in a small district, if you got 10 cases, but they're spread, 2 in this school, 3 in that one, 4 in that one, spread out, it's not as big a deal as if, say, all 10 cases were in the one elementary school in the district, right? So those are the kind of things we're trying to take into account. Is there concentration of the cases, and is there sign of spread?
Okay, and my last follow-up is, uh, so if the district, if the Little Rock School District, which is one of the largest school districts in the state, or any district in the state, wanted to be proactive and go virtual, what would need to happen? Because two, we know that our numbers are climbing. We know that Pulaski County is one of two of the highest positivity rates, right? No one in our state. What would need to happen for us to go virtual? Because UAMS is predicting peaks in the coming months, and then after holidays, we typically see spikes. So, is there anything a district is able to do to be proactive instead of reactive?
Yeah, some school districts have tried various things. And I know Little Rock School District is implementing some of those things. I'll let Mr. Poor talk about the things, Mr. Poor, you were talking about with sporting events, for instance. But as far as going virtual, what a school would need to do if they had an idea, a plan they wanted to come up with, was, call us. We ask for a consult. We compare notes on cases, what the situation is right now, what the trend seems to be in the schools district's cases, and compare that with community and what they're seeing and what we're seeing, comparing notes, and then discuss what the plan is. Those calls have Department of Education folks on them as well, and then we try to come up with a plan.
Okay, and so so the last piece is, for clarity, would be districts will still have to go through like a clearinghouse, the ADE and the Department of Health, in order to go virtual.
Yes, I think that is mainly when it's going to be an extended period of time. I'm forgetting the time period that ADE has put on that. If it's a matter of a few days, we suddenly ran into a shortage with teachers in this school and we just can't have class. Schools have been able to make that decision for a few days. I think it's up to a week. Mr. Poor might be able to inform you more specifically, but it's when it's going to get into, more than a week. We're looking at 2 weeks. We're thinking longer than that period. That's when we want to talk with you and see if that, if we can see anything else that indicates, yeah, that's a good idea, or maybe there's something else you can do instead.
Okay. Well, thank you.
I just want to make one comment real quick on the statistic you provided, and just make sure this is clear for our public. Is Pulaski County does not lead in positivity rate. In fact, it's actually quite low compared to others. And Mr. Tumlison, you can back me up on this. We have risen though in Pulaski County over the last month, and if I remember right, today I think we were about 8.3 or 8.4 on positivity rate over the last week. But if you go compare that then into the Fayetteville region or the Bentonville region, both of those areas, Benton County and Washington County as an example, just for a point of clarity, both of those I think are, and again, it looks like Dr. Thompson's looking it up, but probably around 12%. There are places in our state that exceed 15%, and some are even in a higher percentage rate than that. We do have a large number of cases in our county. I want to make sure that's probably what you're referring to.
Yes, it is. That's exactly what I was referring to.
The total number of cases always, Pulaski County is typically always in the top 3. Dr. Tumlison, anything to add to my comment?
Yeah, you're right. The number of cases in Pulaski County and Benton County and Washington County, the most populous counties are pretty typically usually higher. They've only, not been the highest when there's a pretty significant outbreak somewhere else that's really taken that area by storm. I'm just looking up the Pulaski County data right now. The PCR positivity is 8.5%. The antigen positivity is 15.5%. So you take that in together, it really, the balance depends on, how many of those tests were actually antigens and how many were PCRs. The majority of them are going to be PCRs. The antigen tests are always going to have a higher positivity. Why? Because the people who should be getting an antigen test generally are ones who have symptoms. And if you got symptoms, you are more likely to have COVID as the cause for your symptoms. So that affects that. But yeah, that's the kind of breakdown right now on the positivity rates that I'm showing most recently.
Mr. Tomlinson, I'm so sorry. Vicky,
No,
can
go
I-
ahead. You're recognized. Go ahead.
Well, I just, it struck me just now when we were talking about that positivity rate. Under the CDC's current guidelines, having school, in-person school with that rate of community spread or positivity rate, is that still considered a highest risk or a very high risk under the, I mean, I remember fairly recently looking at guidelines, and they had positivity rate and they had, you know, red zone essentially as the, just, do we fall into that category?
So in the CDC schema, they've got different factors that go red, orange, yellow, and down, right? And positivity rate is one of those, but it's not the only one. The other factors they have are like, are schools actually, you know, doing anything to prevent COVID? And like, if you look at the things that put people in red, it's like they were expecting some schools to just not be doing anything, like nothing. Nobody's spacing, nobody's wearing masks, nobody's taking any precautions whatsoever, as in the red zone. And so that's why we are trying to balance those different factors when we're trying to make the decisions on virtual versus in class.
Okay, thank you.
Okay.
Madam
Well-
Chair, can I have one last follow-up question?
Can you do it in 15 seconds? Because
Yes, I can.
get back on
Dr.
time.
Tumlison, I just want to ask the big conclusory question that hasn't been asked yet. Is it safe for Little Rock kids to be in person in school right now?
I mean, I think it's a matter of what level of safety are we looking for? Is it absolutely safe? No. It's you know, the only thing that would be safe in that respect would be to stay at home, everyone, and not go anywhere. You know, I think it's like Dr. Barr said, we're trying to balance the negative effects of not being in school with the negative effects of potentially being in school. And so, you know, right now with the measures that are being taken, if those measures continue and schools continue to look at their process and make sure they're doing the best they can, I think what we've seen when we've done consults with schools and in seeing time and again that they didn't get it in school, they got it outside. There's very little spread in schools, and we've not, you know, just very isolated cases, sports teams, things like that, where there's been, you know, there's been spread in a group. Because of that, it makes me think that, you know, it is relatively safe comparing what else they might be doing if they weren't in school. It is relatively safe being in school. Is it absolutely safe? No, it isn't. But I think it is relatively safe compared to the other things they might be doing if they weren't in class.
Yeah, I would echo that, and the article that Jeremy distributed, I think addresses some of the, you know, there are risks to being in school and there are risks to not being in school, and I think that I applaud you all for dealing with these questions and struggling with, you know, that decision. But I think that there are risks on both sides, and it's really weighing, you know, the risk-benefit ratio of that decision.
And just to be clear, your question, are you talking about the safety for students, or are you also including the adults, the teachers, the staff, the faculty in that answer?
Director Nolan, was that for Dr. Barr or Dr. Tumlison, or both? The question. You're muted. You're muted. You're on mute.
I think that the answers that were given were really specific to students, and I may be wrong, but I just wanted to clarify whether we were just talking about students or also about whether it was safe for the adults in the school at the same time.
And my comments were related to kids, effects on kids.
Yes, ma'am. When I was thinking of my comments, I was directing them primarily toward kids. I think a similar risk-benefit analysis would have to be done for adults as well, right? And I think with precautions in place, that it can be a relatively safe environment for adults as well. Obviously, their risk of having a severe case of COVID is somewhat higher. It is higher than children, especially small children, than if they're adults. But most of the adults that we've seen have B cases, have gotten their COVID outside of school as well.
Okay, so Dr. Barr and Dr. Tumlison, we thank you so much for coming to address the board and to answer our questions as the best as you could, and helping us as well as the community with information to move forward. So we definitely thank you for spending a good bit of your evening with us. I will turn it over to Mr. Poor to see then if he has any closing remarks for both doctors.
No, thank you, gentlemen, and appreciate your time and investment in the Little Rock School District. And it's not just a one evening thing. You guys are there for us. So very much appreciate all the time that you and your organizations put into us. Thank you.
I'd like to say thank you for the work that you all do, and we deeply appreciate your roles with educating children. Thank you.
Thank